Good afternoon, everyone. We're going to have a session on updates on the management of rosacea with Dr.Mairie. Before we start, I wanted to say welcome for everyone that has participated on this session. So to start with, I want to say we're going to have pre and post taste on this session, and I'm going to tell us highlights about our CME and yet in our life. And Dr. Hunda will continue.
Okay, good morning, everyone. Good afternoon, sorry. KDVS representative, this is to introduce Dr. Mairie Guizaw. She's a dermatologist, part of our EDVS. She received her certificate in specialty of Dermatovenerology in the year 2012 and has been working as an assistant professor at Ayder Hospital from 2012 to 2015. Currently working in the private sector and coming here to represent us on the management of rosacea updates. Thank you.
Thank you. Thank you very much, Dr. Hunda. Can Amisyas give us some introduction about our CME? I'm sorry, Dr. Mairie, can you stop sharing your slides so that Amisyas can share his slide, please?
Someone?
Yes, you can hear you.
Yes, yes, someone.
This CME is one of the programs under Getenaweg, and Getenaweg is a group of Getenaweg is basically a group of health professionals working for this developing evidence-based medicine. We started with 2 people, and now we have more than 113 volunteers with diverse backgrounds. Our organizational structure looks like, as you can see, just an assistant professor at Thomas Jefferson University Hospital and Dr. Ermias Giroux, pulmonary and critical care physicians who are the founders of Sunlight, who has books as head of programs. So our program focus are increasing access to evidence-based information to the public, as well as to health professionals and the training and mentoring of healthcare workers. So the programs we are currently working on are health promotion, health advocacy, CME or continuous medical education, and mentorship. So we have different sub-programs under each main programs. We have different partners, Minister of Health being the first and the main partner, and we also work with AIMA in Gender Health, Ethiopian Medical Students Association, and our today's partner organization, the Ethiopian Dermatovenerology Society. We also work with the Ethiopian Cardiac Society and the Nurses Association. Also, Brand ET and Malafia are some of the organizations that are working with Getenaweg. And as you all might know, Getenaweg is a creative space for young professionals who want to shape the future of the healthcare Ethiopia. So we would like to encourage everyone to participate and volunteer in Getenaweg.
Thank you very much, Amisyas. So now let's proceed with Dr. Mairie. You can continue your session. We're not able to see your slide. Yes, it has started. Thank you.
So this is a session on the updated management of rosacea. These are the objectives. The objective of the session is to be reminded about the main pathogenic factors in rosacea development, to describe the two classifications, and to mention the diagnostic criteria regarding the new phenotypic classification of rosacea, to list topical and systemic therapies, and in regard also to the updated recommendation, and finally, to summarize the approach in the treatment of rosacea. So this is the outline. As we know, rosacea is a chronic recurrent inflammatory dermatosis that mainly affect the center of the face. The forehead, the cheeks, the nose, and the chin are the common sites, but the chest and the neck can rarely be affected. The prevalence is said to be lower in Black and Asian skinned individuals, and more commonly seen in fair-skinned individuals with skin type 1 to 3, with a high prevalence of 10% to 12%, and the overall prevalence in 2018 was said to be 5.5% among adult population. So females are said to be more affected than males, with 3:1 ratio, and males are said to have more severe diseases. Young to middle-aged individuals are more commonly affected, but again, children, adolescent, and elderly individuals can also develop rosacea. So as to the cause of rosacea, the specific cause or the cause is not well understood, but it's a complex interaction among genetic susceptibility, abnormal vascular reaction, dysfunctioned immunological response, high density of dermodex mite on the face, and also a list of environmental factors that trigger or flare up or even worsen or aggravate the rosacea skin lesion. So it's treatable, but again, incurable. So in the skin of color, we said that the prevalence is said to be lower. One of the reasons is because of the underdiagnosis, which is masked by the increased epidermal melanin, and this also results in underreporting. Again, the other reason for prevalence, lower prevalence in skin of color, is because of the protective effect of melanin against ultraviolet radiation, as ultraviolet radiation is one of the important environmental triggers that can worsen rosacea on many or with many different mechanisms, with resulting chronic damage to the dermal connective tissue and further weakening or the facial supportive tissue and weakening the facial blood vessels, with endothelial damage resulting in leakage, edema, and inflammation. And also one of the other reasons is because of the lower incidence of genes which confer susceptibility in rosacea. The other, in fair-skinned individuals, the persistent facial erythema and telangiectasia are said to be the commonest form of features in the presentation, and because of the decreased erythema, which is seen in dark-skinned individuals, the inflammatory papule type is a frequent manifestation. So this is one of the difference in rosacea in skin of color. So regarding the pathogenic factors, so these are very important because the treatment is addressed regarding these pathogenic factors. So one of the factors is genetic susceptibility. Certain genes have been identified in rosacea, and these genes have been linked to autoimmune diseases like rheumatoid arthritis, multiple sclerosis, and this link is said to be consistent with the inflammatory nature of rosacea. So the overexpression of certain genes making individuals susceptible for rosacea plays a role in the innate and adaptive immune response. With exposure to certain environmental triggers, the skin reacts in a very aberrant or hyperactive way, resulting in this cascade of inflammatory reaction. So the other factor or element in the pathogenesis is inflammation. Inflammation is an important part because the nature of the disease is inflammatory, and also most of the treatments, topical therapies, and also systemic therapies like the antibiotics target this process. So there are a number of mediators that have been released, like the antimicrobial peptides with LL37 catecholamine with other various peptides resulting or aggravating inflammation and resulting in also vasodilation. The other factor is the abnormal vascular reactivity, and this results from inflammation, vasodilation results from inflammation, or with certain environmental trigger like hot temperature, direct vasodilation can occur, resulting in increased blood flow and flushing, and further down, resulting in a persistent erythema and angiogenesis, which also lead to telangiectasia. So drugs like topical adrenal receptor agonists, oxymetazoline and bromidine, target the vasculature, the superficial blood vessels, resulting in vasoconstriction and further down, resulting in decreasing erythema. The other component is a neurogenic dysregulation. Patients in rosacea, they have a lower neural threshold for certain stimuli. So they react in an exaggerated way, or they have a low threshold. So that's one of the reasons why patients have burning sensation. And this transient thyroid receptor potential ion is also one of the important potential channel that plays a role in temperature perception, and also is said to be expressed in the erythema, percentage erythema. So rosacea patients, they have increased susceptibility to triggers, and these triggers, unlike normal individuals, provoke an exaggerated immune response. Immune detection and response is not normal in normal individuals, but rather because the immune system is dysfunctional, it identifies it as an abnormal way and resulting in inflammation and further damage, causing inflammation and vasodilation with the clinical feature of persistent erythema or transient erythema, telangiectasia, inflammatory papilla and pustules, and also further down with thymatus changes. The other important role in the pathogenic factor is the role of microbes. Dermodex mites, the Dermodex follicularum, is strongly associated in rosacea as it is found in high concentration in rosacea patient dining control individuals. And of course, ivermectin cream is one of the topical therapy that is advised, especially for the inflammatory form of papulopustular or inflammatory papilla and pustular lesions. And also be continued with as a maintenance therapy. So Dermodex brevis is also often present in the eyelid and the eyelash follicle, which result in blepharitis and is said to be responsible for ocular rosacea. The other possible role in microbes is the association of H. pylori infection in rosacea, and is said to be unclear because some studies show that rosacea patients have high prevalence of seropositivity of H. pylori infection, and others didn't found this to be true. The other important factor is the abnormal barrier function, and this is why patients have a dry skin and irritated skin because of the increased transepidermal water loss with a decreased epidermal hydration. So again, in the treatment, addressing the skin barrier function by using moisturizers containing ceramides or hyaluronic acids is very important to hydrate the skin so that there is decrease in dryness and irritation of the skin. The other factor is the environmental factor, which can be in terms of external or internal factors. Internal factors, which can be stress or also foods or alcohol intake and so on, and external factor like ultraviolet radiation. And they have a direct effect like hot temperature resulting in vasodilation, or they can have indirect effect also further down causing inflammation and vasodilation at the same time. So ultraviolet radiation again, can result in damage to connective tissue and further resulting in dysfunction of the unsupported facial blood vessel with endothelial damage, leakage, and edema and inflammation. And also it can result in a high level of reactive oxygen species, which are said to have a pro-inflammatory effect. So these are the list of environmental factors with specific prevalences. We can see that sun exposure is one of the important environmental factors, which is strongly associated with flare-ups or aggravation, or even for the development of rosacea. Hot drinks, spicy food, red wine, beverages, extreme temperature, exercises, stress, hot baths, certain irritating skin products, harsh soaps, or other products that can irritate the skin, and also medications that can result in vasodilation, like calcium channel blockers, niacin, nitrates containing drugs, are said to aggravate rosacea. So this is the summary of the pathogenesis of rosacea. In early rosacea with a persistent facial erythema, in the presence of genetic susceptibility and exogenous factors like ultraviolet radiation, heat, certain toxins, or environmental triggers, there will be release of certain inflammatory mediators by the immune cells, and this results in vasodilation and inflammation. And at the same time, genetic predisposition with endogenous triggers like spicy food and even fatty meals, which are said to have a role in rosacea, can also activate certain sensory nerve fibers and release of neuropeptides, which result in inflammation and vasodilation. So this is the same. And finally, resulting in flushing, stinging sensation, and also inflammatory lesions, erythema, and telangiectasia. So clinically, patients have history of flushing, which is transient, and further down, patient present with persistent erythema and associated burning sensation, inflammatory papules and pustules, and also visible blood vessels, which is commonly seen over the medial aspect of the cheeks and the nose, can be observed, and also phimosis changes can be seen in patients with rosacea. Ocular changes is seen in more than 50% of patients with irritation and crests on the formation on the eyelid area, conjunctivitis, and so on can be there. So the previous classification, the subtype classification, there's 4 subtypes and 1 clinical variant, which all of us have been using clinically. There's dermatovenerology, papulopustular, phimosis, and ocular, which is based on primary and non-primary features. And this classification from subtyping is evolving to phenotyping, because the global rosacea consensus panel has proposed a phenotypic approach, which is said to be more beneficial for patients. And this is more advised or more preferred because it's said to more accurately reflect patients which are seen in the clinical practice. So the subtype, there is overlap of certain cases like the erythematosus telangiectatic, whereas here patient can be targeted with a dominant telangiectasia or dominant erythema versus persistent facial erythema. So flushing and telangiectasia previously were not considered diagnostic individually, but this in this classification, it is isolatedly recognized so that patients benefit targeted in these characteristics. So it also has a therapeutic implication, as this phenotypic classification advise the treatment to be tailored based on the individual clinical experience. So this is also one of the important benefits or why it's preferred. So these are the so patient can have overlap. They can have transient flushing, which is one of the major features. They can have a persistent erythema, which is one of the diagnostic features. Inflammatory papules, telangiectasia also can be targeted, or treatment can be targeted for these features. So one, at least diagnostic feature, or two major features are important. Rosacea, the diagnostic features, persistent centrofacial erythema, is periodic intensification by potential triggers, is one of the diagnostic features, and phimosis change is also said to be one of the features. Transient erythema or flushing, inflammatory papular pustule, telangiectasia, ocular manifestation like telangiectasia, blepharitis, and so on. These are some of the major features. And the minor features, burning sensation. Patients usually have a burning sensation, stinging sensation, dry skin, edema, and other forms are said to be minor features of rosacea. So regarding the treatment options can vary from topical therapies or systemic therapy with systemic antibiotic or topical antibiotic, topical anti-inflammatory agents, to topical adrenal receptor agonists, and also laser therapy, physical modalities, including therapy, and also surgical intervention for the phimosis type of rosacea. Topical therapy, one of the cornerstone of treatment in rosacea, and the aim of the treatment is to decrease the inflammatory lesions, papilla in the pustules, to decrease erythema, to decrease flare-ups, and also to treat the symptoms. Patients have discomfort because of the burning sensation, because of the stinging sensation, and dryness. So one of the common drug which is given is topical azelaic acid, which is an anti-inflammatory and used for mild to moderate inflammatory lesion, and in severe case, which can be combined with doxycycline. So it is said to have a comparable effect with topical metronidazole, and topical metronidazole is said to be more advised just because of the risk of burning and stinging sensation in relationship with topical azelaic acid. So topical metronidazole with this 0.75 J 1% cream, it's one of the commonly used drug, topical therapy, which has a good treatment outcome. So the main mechanism of action is anti-inflammatory effect. So it results in inflammatory lesions. So are advised to give for mild to moderate disease. It's said also to decrease erythema, as erythema results from inflammation. It's generally well tolerated with mild adverse events like irritation, pruritus, and dry skin. But compared with topical azelaic acid has more side effects than metronidazole. Again, some studies say that they have comparable effects in regard to decreasing inflammatory lesions, and some advocate that there needs to be established with further studies. The other topical therapy is ivermectin 1% cream, and this drug plays a role by decreasing the Demodex mild concentration on the face, which again plays a role in rosacea patients, and also by its anti-inflammatory effect. The study has shown 80% clearance of inflammatory lesion after using for 3 weeks. So it's said to have an increased efficacy, and which has increased even efficacy compared to metronidazole. So it's given for mild to moderate, and treatment can continue up to 3 to 4 months. It has a safety profile with just mild dry skin and pruritus. seen in certain patients. Other topical therapies are the topical oxymetazoline and topical brimonidine J, which are adrenergic receptor agonists. And this results in this affect the vascular tone by resulting in vasoconstriction of the superficial blood vessels. So it's well tolerated, it's effective, and the action is immediate within 1 hour and reaching peak within 3 to 6 hours. And it can last for 12 hours. So morning application is advised for patients with persistent facial erythema as the erythema decreases within an hour. Certain patients develop pruritus and dermatitis. Again, it does not have effect on telangiectasia and also the inflammatory forms of rosacea. This is more given prescribed for persistent facial erythema. The other adrenal receptor agonist is brimonidine, which is primarily introduced into the market and approved. It's said to be as effective as oxymetazoline, but one of the downside of this medication is patient can develop paroxysmal erythema. That is, after application, within 3 hours, they can develop worsening of erythema than the baseline. So patients should be advised for a possibility of paroxysmal erythema. And the other problem also with brimonidine is the rebound is high compared to oxymetazoline, in one report showing up to 20% of rebound after discontinuation. So this should be also advised to patients. So these are the concerns with using brimonidine. Otherwise, it has an immediate effect, even immediate effect compared to oxymetazoline, and decrease in erythema is seen within 30 minutes to 1 hour. And again, it lasts up to 12 hours. So it can be given to persistent patient with persistent facial erythema, even in combination with other topical medications, if patient have also inflammatory lesion. And again, these topical adrenal receptor agonists, they do not have effect on telangiectasia. They don't target these capillaries. So this is a picture showing that patient has an improvement of erythema 1 hour after application of this. The other topical therapy is the use of topical minocycline. Systemic minocycline is one of the medication that is used for moderate to severe inflammatory rosacea. But because of the side effect, even if they are rare, they are not advised compared to the use of doxycycline. But topical therapies have been formulated with a formulation and showing improvement as early as 4 weeks for the inflammatory rosaceas. So eczema, burning sensation, worsening of rosacea can occur. Otherwise, there is negligible systemic exposure. The other categories of treatment in rosacea, topical therapies in rosacea, is topical retinoids. So we said that rosacea patients have an increased sensitivity to certain topical agents. They can have dryness and irritation. So specifically the tretinoin 0.25, tretinoin 0.5%. Usually patients do not tolerate this medication because of this drying effect, because of the irritating effect. But adapalene 0.1% as an anti-inflammatory effect has said to have greater efficacy compared to metronidazole with decreased irritation. And patients are said to have better tolerability in the use of adapalene compared to the tretinoin. Topical calcium inhibitors, tacrolimus 0.1% ointment and pimecrolimus have been shown with improvement, but they are costly and they are limited only for treatment-resistant form of rosacea. And one of the rare side effects is rosacea-like eruptions. So they are not given here and there, but rather they can be reserved and can be given for patients, for example, for steroid-induced rosacea. Patients, especially if not responding with topical therapies, this medication can be prescribed. Topical dapsone, 7.5% gel as an anti-inflammatory, can be given once daily for up to 12 weeks. It is said to be as effective as metronidazole 0.5% when given for this amount of duration, 12 weeks duration. So it's also one of the treatment modality, topical modality that have been used in especially the inflammatory form of rosacea. Other treatment options, as some case reports show, is the injection of intradermal Botox. And this is said to have an improvement for transient and persistent erythema flushing. And this is based on case reports. And the mechanism proposed for this is, as it interferes with the release of acetylcholine, it results in it addresses the vasodilation, so it's giving a symptomatic relief of flushing and erythema. So the other also possible mechanism is said to stabilize mast cells to prevent a release of inflammatory mediators so that it can address inflammation. And this is said to better be given with physical devices like IPE. Permethrin 5%, again, is one of the anti-inflammatory agents that is proposed as it targets dermodex mite. And in twice daily, used for 2 months, said to be superior to metronidazole, 7.5% gel. So, but again, it's not effective in telangiectasia or even pharmatus lesion and pustules. Benzyl benzoate also, as it addresses target dermodex mite. Some studies show that it can result in 98% reduction of mite, which has in fact increasing the inflammatory lesion of rosacea. Other topicals, clindamycin, cream or gel, topical erythromycin solution, sodium sulfacetamine and sulfur have been also been used for patients. Systemic therapies. Systemic therapies are also given for rosacea in especially moderate to severe cases, and antibiotics like the tetracycline groups or isotretinoin, or certain medications like hydroxychloroquine as an anti-inflammatory effect has shown to result in decreased inflammation and also decreased lesion in rosacea. So the aim is to improve the rosacea to the point where control can be achieved with can be continuous topical therapy. And it can be given as a minimum of 4 weeks and prolonged to many months to suppress the flares. So lower doses, doxycycline 40 milligram or isotretinoin 10 milligram can be given, and this lower dose is preferred because it has lower side effect. There are tetracycline derivatives, drugs like tetracycline, minocycline, doxycycline. So doxycycline, minocycline are commonly used, as well as other systemic antibiotics. Specifically, because of the side effect of minocycline, doxycycline is usually given, and 40 milligram and 100 milligram dose are said to have equal efficacy, but 40 milligram is preferred to minimize possible side effect and also drug resistance. So most patients achieve a clearance of lesion or almost clearance of lesion, and also because of this anti-inflammatory effect, it can also result in a reduction of erythema. So photosensitivity is one of the concerns. Of course, rosacea patients use sunscreen, so it's part of the treatment modality. Minocycline can be given in 50 to 100 milligram twice daily dose, and the effectiveness of minocycline is said to be as doxycycline. In some studies saying that minocycline has a more effect and it's more infectious, it's more effective than doxycycline. But again, in general, they are said to be comparable. Again, one of the problems with minocycline is the severe adverse events, which even though are rare, like hyperpigmentation, strike reaction, autoimmune hepatitis, unlike in doxycycline, in which the main side effect is the GI upset. So erythromycin, clarithromycin can also be used for refractory cases. And azithromycin has also shown no difference in the effectiveness as used when used with doxycycline 100 mg, can be given in 3 times weekly or daily for 2 weeks. Metronidazole, especially erythromycin, can be also given for 5 weeks. The other systemic therapy is isotretinoin. And this again is given for severe inflammatory cases, rosacea, or for phimosis rosacea. So as it results in 90% reduction of lesions, patients have a significant improvement in the quality of life. So one of the impacts rosacea have is it can result in lower self-esteem, lower confidence, and also shame, embarrassment because of the phimosis change, or even anxiety and depression can occur. So this treatment is said to have a significant improvement in the quality of life of patients. So lower dose is preferred with lesser side effects, and of course routine laboratory and the issue of therapeuticity should always be in mind. Beta blockers like propranolol is given for flushing, transient erythemas, and the effect is by antagonizing the effect of catecholamines, which are said to result in dilation. So it is, if it's prescribed, it should be given at a low dose at the risk of hypotension and fatigue and so on. So the other beta blocker is also carvedilol, which showed a significant improvement when used for 6 months. The other anti-inflammatory agent that studies show to be promising is hydroxychloroquine. Of course, 100 milligram use of doxycycline when compared to 200 milligram twice daily hydroxychloroquine given for 8 weeks, it has shown to have equally efficacious result, and with minimal side effect, only dry eyes, dry skin, which is also good. So in the approach, in the management of rosacea, one of the important things to be reminded is patient education, as all those lists of environmental triggers can flare up, can aggravate or worsen skin lesion, erythema, and also inflammatory lesions. So patient education, that's rosacea is treatable, but again, incurable, and addressing these triggers should be important, it's important. So patient education is one of the important parts of treatment. Essential skincare, general measures. So these general measures are important because they are driven to help in the result of a better treatment outcome. Use of facial cleansers, which are gentle, so that the skin is not irritated or dry, is advised with moisturizer, using moisturizer containing these ceramides, because it's important to repair the skin barrier function, as one of the mechanisms in rosacea is the abnormal barrier function effect resulting in dryness, irritation of the skin. Of course, applying sunscreen is the mainstay of treatment, which should be continued at least once or twice per day, and preferably physical sunscreen are advised because they reflect back the rays rather than the chemical sunscreen that can result in hotness in the skin because of the absorption. Avoidance of triggers, of course, is very important as it can irritate and further down worsen skin lesion. Even for ocular rosacea, avoiding periocular cosmetics is one of the advice that patients should be given. So specifically for persistent visual erythema, for mild to moderate topical premonition oxymetallurgy can be given, and additionally IPL or other form of laser can be of beneficial. But again, metronidazole gel and azelaic acid can also be given for persistent visual erythema, as they can target the inflammation, which further down results in vasodilation. So treatment can be used as monotherapy or combination, and can be used in concurrently or in staggered fashion. Telangiectasia treatment options are mainly physical therapies or physical devices rather than topical medication. They don't really address these capillaries, small capillaries. So electrodesiccation, especially for small and superficial blood vessels, can be advised, but the risk of scarring is there. IPL and lasers also can be advised. So light therapies like IPL or the PDL therapies target the oxyhemoglobin and blood vessels, resulting in selective photothermolysis and decrease in the erythema further and telangiectasia. But this light therapy and laser therapy in rosacea, they have shown also to reduce the number of dermodex mites, which is also a beneficial effect in treatment of rosacea. So IPL is said to decrease the erythema and the telangiectasia, but does not decrease the frequency of episodes of the flushing. So when patients are treated, the erythema and telangiectasia can decrease, but further down does not guarantee a decrease in the frequency. PDL also targets the oxyhemoglobin in rosacea of the blood vessels. Again, patients can have pain is one of the concern, the presence of pain, and also post-op purpura, which can last for 1 to 2 weeks. The NADIAC is preferred in dark-skinned individuals having rosacea because it has a decrease in absorption of melanin. So in a comparative study, in a split phase study, randomized study, when patients have been, when PDL and NADIAC have been used for 4 sessions, patients prefer PDL even in the presence of pain compared to NADIAC laser. So NADIAC is preferred for dark complexion, and also is said to be better for the recalcitrant telangiectasia that occurs over the ala nasal and also the tip of the nose, which did not respond to IPL and inflammatory rosacea. If it's mild and moderate, a combination of topical therapy and systemic therapy. Again, the commonly used and the topical therapies with strong evidence are azelaic acid, ivermectin, and metronidazole. But again, other medications that have been can be used, and of course for severe and refractory form, isotretinoin is considered. So the phymatous change of rosacea is one of the severe forms of rosacea, which is seen commonly in males, and out of the phymatous change, rhinophyma is common. with edematous lesion involving the nose, erythema, if it's inflamed, and soft tissue excess. And this results from sebaceous gland hyperplasia, chronic inflammation, edema, and vascular overgrowth. So initially, it presents with just slightly thickened skin and uneven skin, but later on developed to progress to nodules and of course, resulting in huge psychological impact. So the treatment of phymatis change mainly depends whether there's inflammation or not. If there is inflammation, doxycycline as are given to halt the progression by treating the inflammation. If it's non-inflamed, the fibrotic phyma is addressed to debulk the soft tissue excess with a minimal scarring. So excision with surgery or even ablative lasers can be advised, but again, this is given for non-inflamed. This is non-inflamed phymatis. And scarring, again, depends on the depth of excision, which is also one of the things that is that needs to be addressed. So this is a patient with A and B pictures before treatment, and 4 years later, after consecutive use of ablative to laser, with a significant reduction of change. And the other forms of phyma is gnatophyma. And there are reports in this form of phyma where most of the reports show that there is association of dental problems or tooth decay in this type of phyma. And patients present with soft tissue mass, with nodularity, with telangiectasia and erythema. And there are different medications that have been used in the reports, systemic antibiotics and also topical antibiotics and severe cases, laser, around and electrocautery have been used in the case report. So this is a patient before a treatment, and this is after 2 months. But again, the patient in this scenario has lost for follow-up after small reduction of vision with systemic therapy. The other form of phyma is otophyma. Otophyma is a phymatous change which occur on the outer third part of the external urinary canal. So one of the concern here is because of the obstruction of the auditory canal, there is deafness. And there are reports of bilateral involvement with bilateral deafness. So one of the treatment targets in maintaining a patent external auditory canal. So reports show improvement with azotretinone, doxycycline, and of course surgical intervention, removing the mass, as shown in this patient, where there is this phymatous change on the external auditory canal, and then after removal, you can see that it's no more there, and it's a successful treatment. Other forms of phyma, blepharophyma, involving the eyelid area, and also mentophyma. These are also rare forms of phymatous lesion. But again, this show us that we have to be keen to diagnose in this atypical sites beside the rhinophyma. So this is a summary of the treatment modalities for the different characteristics of rosacea in presence of persistent erythema. Alpha-adrenergic agonists like the oxymetazoline and brimonidine can be used. Also, beta blockers can also be prescribed. In persistent erythema, a topical agents, also physical light therapy or laser therapy can also be advised. For inflammatory lesion, for mild to moderate topical therapies, or not responding severe cases, systemic antibiotics like doxycycline can be advised. And for severe cases, doxycycline from the outset, and again, azithromycin can be considered as recalcitrant. Telangiectasia does not really respond to topical therapies. It's said to respond with physical devices. And again, the phymatous form of rosacea are treated with systemic therapies and topical therapies if they are inflamed, or with excision and ablative lasers if non-inflamed. So again, this is one of the summary table for the treatment of rosacea in regards to the different clinical characteristics according to the phenotypic classification. So in the follow-up, the general measures should always be advised to patients, should be always reminded, and patients usually appointed 6 to 8 weeks, whether topical therapies or systemic therapies, and it's recommended to continue treatment for 6 months to maintain the remission and to prevent flare-ups. So topical therapies for maintenance, studies show that effectiveness of combination therapy is by using more than one therapy, combination therapy. And the usually recommended medications for topical maintenance therapy are the ivermectin, metronidazole, and azelaic acid gel. So certain forms of rosacea, steroid rosacea, which occur at repeated use of oral systemic oral or topical steroid, and patients present with monomorphic lesion and typical background of erythema or persistent visual erythema. And again, even here, systemic antibiotic and also sometimes tacrolimus is said to have an important effect in rosacea. So the other form for rosacea is ocular rosacea, can be mild, moderate, and severe. And mild cases are usually treated with lead hygiene or with warm compress, and also with artificial tears, as the eyes are said to be dry in rosacea, and also to advise patients to avoid smoky environments. Is also one of advice, and also avoid periocular cosmetics, not to irritate the eyelid. Topical azithromycin can also show improvement symptoms when using 1% solution. For moderate cases, cyclosporine 0.05 is given twice daily, and it has shown to have a good response in resulting in better outcome in ocular rosacea, especially for moderate to severe cases. The other is omega-3 fatty acids are said to have an important good outcome or good influence, especially for dry eyes, with improvement in showing improvement in their gland function. So the quality of life is one of the important parameters patient should be assessed in clinical follow-up, as most patients, especially in fair-skinned individuals, most patients have low self-esteem, low self-confidence. They are embarrassed, and they have social phobia and so on. So that should be addressed in the treatment. And depression and anxiety, especially for severe forms of rosacea like the phymatous change, has been observed. And this should be addressed if necessary. And again, one should avoid also stress. It's one of the triggering factors which can result in a vicious cycle. So the overall prognosis of rosacea is good. psychological impact like anxiety and depression should be watched for and looked for. And if untreated, persistent erythema can result in post-inflammatory hyperpigmentation, or sometimes the inflammatory lesions can result in scarring. So scarring, post-inflammatory hyperpigmentation are the other thing that we can see in patients with rosacea. This is how my references. Thank you.
Thank you, Doctor, for an excellent presentation. We can proceed to the question and answer. There were 3 questions that was asked. The first one was, how can we differentiate phenotypic and subtypic?
Can you repeat, please?
You can check it on the chat box.
Okay, okay.
And it says, how can we differentiate phenotypic and subtypic? We can go to the next question, maybe.
Can you repeat the question? I could not find the question on the chat.
Oh, okay. Let me read it for you. It says, how can we treat pregnant women who has rosacea? Is topical treatment safe for them?
Okay. It depends on the type of, on the clinical characteristics of rosacea. Patient can have persistent facial erythema, which responds to topical therapies, to topical medications, or if it's moderate to severe, erythromycin is one of the medications that can also be given for systemic therapy. But again, the general measure should be advised as any other patients. Otherwise, erythromycin is one of the, if severe, drug that can be given for patients with rosacea in pregnancy.
Okay, thank you. The next question is, are there any drug which is curative, because most of the drugs are symptom control?
There is no medication that can cure rosacea. All the drugs that are targeted have different mechanism of action, mainly the inflammation and vasodilation. So this is what recommended. Otherwise, because of the nature, there is genetic susceptibility, there are environmental triggers, and so on. So because of the clear different factors of different pathogenic factors in rosacea, there is no as such one medication that can result in cure, but rather it's a recurrent problem. But one can decrease the recurrence by avoiding triggers, and in certain cases, like for those using, for those having persistent erythema, for example, because they have frequent flushing and flares of flushing, they can also give laser therapies or light therapies in a maintenance form, like twice per year and so on, to decrease. Otherwise, there is no as such medication that can result in cure because of the complex interaction and the triggers. But the main the main advice is to avoid the triggers, to decrease the trigger, rather than to aim for treatment that results in cure.
Okay, thank you. The last question will be, how is rosacea significant in Ethiopia? They wanted to know the numbers and, you know, the significance in Ethiopia.
The significance of rosacea in Ethiopia, of course, we have skin type, type 4 to 6, so we have deeply pigmented skin, but even if there is no such prevalence study, in daily clinic, we see patients with rosacea with different clinical characteristics, mainly the inflammatory rosacea, and also in fair skin with erythema and also telangiectasia. Despite lack of studies, rosacea is common in our setup, in our society. And again, treatment is addressed as it has been mentioned before. So it's common, but there are lack of studies according to the prevalence. But again, this is one of the areas that we should do studies.
Thank you, Dr. Mairie. I think the questions are, here are the questions. I will leave the floor to Dr. Hunda to tell us about the certifications.
Okay, thank you. The certification for this CME session will be provided by the Ethiopian Dermatology and Venerology Society. We normally have certain criteria to get the certificates. One is you have to get more than 50% of the questions answered in the post-test. And the second is the EDVS asks charges for a payment for the certificates. We have a 200 payment for each certificate. You can get the further details from our Telegram channel. We have the Ethiopian Dermatology Venerology EDVS on Telegram. And through that, you can go further to get your certificates. Thank you.
Everyone makes sure to answer the post questions and also fill the form so you can get your certificate.
Thank you, Dr. Mairie, for the excellent session. We'll be sharing the YouTube and other links of Yetinawek on the chat box. Thank you for participating.